Carol is currently completing her MBA HCM while she has obtained her MBA from Swiss Business School and Bachelor from the University of Tennessee Center for Health Sciences. Recently joined as the Outpatient Service Manager at American Hospital in Dubai, UAE. Professional background, 32 years experience in obstetric and women's health and participated in the commission of Danat Al Emirat and Emirat hospitals in the UAE. She also served on Sidra project in Qatar. She's a member of the Association of Women's Health, Obstetric and Neonatal Nurses. So now I'm passing her the stage to deliver the speech. Welcome, Mr. Carter. Ms. Carter, sorry.
Great, thank you so much. It's a pleasure to join you today. I am going to go ahead and see if I can share my screen so we can go ahead and get this going. Sorry, I'm trying to make it full screen for you guys. I'm going to speak with you today about something that's very near and dear to my heart. It is about obstetric bundles. There are a lot of patient care safety bundles that are available in multiple topics and areas of healthcare. But because women are still actually dying from childbirth, even in the 21st century, and it's at alarming numbers, we need to truly focus on this. And there are things that we can do to prevent, because a lot of these deaths are preventable. So if you're not familiar, I would love to share with the rest of the world, especially in the UAE, to talk about getting care bundles started. So what is a obstetric bundle and why do we need them? Well, this is from IHI, and it's their definition. It's a bundle is a structure of improving care processes. And it's just using evidence-based practices. We're making them outlined. When you perform all these steps and processes in a certain sequence, they have proven time and time to have actually saved lives and improved patient outcomes. Because we're going to focus today, there's multiple, like I said, multiple topics in healthcare, multiple topics within women's health and obstetrics. We know these three are still the leading causes of maternal deaths in the world. So there's postpartum hemorrhage, severe hypertension, and venous thromboembolisms, and a lot of these are still preventable. So just bear with me. This report was from 2015 from WHO, and I know they were doing some more research and trying to update their data from 2017. But every day, approximately, according to WHO, 830 women die from preventable causes related to pregnancy and childbirth. 99% of the maternal deaths occur in developing countries, and it's estimated that 303,000 died during the year following a pregnancy or childbirth. Most of these deaths occurred in low resource settings, and most could have been prevented. And we're going to talk about those measures today. This is UNICEF's report, just a quick slide, just indicating the complications with pregnancy and childbirth. And we still you can notice in this slide that hemorrhage still takes up the majority of the complications that we're still dealing with. So basically when an emergency happens, and we know in obstetrics they can happen in a matter of seconds, are you ready? And are we prepared in the event of an emergency? So the way we can prevent some of these maternal deaths and morbidities is make sure that we have these deliveries attended by health professionals, our doctors, our nurses, and our midwives. Make sure we have proper equipment and supplies. If your facility is one of those facilities that doesn't have a lot of resources, when you recognize that there's a problem, that we actually go ahead and make those referrals in a timely fashion. So some of the complications that can occur is the ability to perform a C-section in a timely manner, antibiotics availability, life-saving drugs, blood transfusions, and the ability to perform other surgical procedures. And it's not always hysterectomy. We're going to talk about some of those today. I love checklists, and bundles are really great. They provide you checklist. And that way we just, in the event of an emergency, when everybody's excited, the adrenaline's flowing, it's nice to have a clear outline of step by step so no one forgets what they're supposed to do. We always, always, always in our practices want to use evidence-based processes. And there's multiple studies, and you can see in my references, and you can research this as well. These evidence-based processes do decrease the morbidity and mortality. So what these bundles also do is it provides guidelines with step-by-step directions. So it's very clear as to what needs to happen. So where do I find these bundles? Well, the IHI, the Institute for Healthcare Improvement, is a great, fabulous resource and organization. AIM is the Alliance for Innovation of Maternal Health, and that's associated with ACOG. There's A1. I also know that WHO has bundles as well. And also out of the UK, the Royal College of Obstetrics and Gynecology, they have bundles. So there's plenty of resources to be able to access this. So you can organize some of your departments and plan for emergencies within your own institutions. If you're not familiar with IHI, they've been around for over 25 years. It is based off ways to improve our healthcare, to improve patient safety, save lives, and also better outcomes. Because we're here to improve and protect our patients, not to cause harm. Also, the Alliance for Innovation on Maternal Health. This is a collaborative group in the US, and some of the bundles and some of the initiatives that they've done have actually reduced at least 1,000 deaths, mortalities in the US during 2014 to 2018. So let's take a look at what a bundle looks like. So first, we need to be able to recognize that a patient is at risk, and we need to recognize when the emergency is actually happening. So first, we need to do our risk assessments on our patients. This is going to begin basically from the obstetric clinics and offices before they even arrive to the hospitals. We want to use universal active management of third stage of labor. This is for every patient that we have. Every inpatient department should have a blood bank, and make sure that you have a massive transfusion protocol, an MTP. Then you need, I have set these up in other institutions, set up for a postpartum hemorrhage or a hemorrhage cart, and we'll go over what that entails and what's included. Have a hemorrhage team and education and drills for those that are involved. Make sure on your response with every hemorrhage that you go through the checklist, and we're going to break down the different stages and categories so we know what to respond at what point. We also need to remember, don't forget the patient. It is a very scary thing when the patient begins to bleed. The medical team gets all excited and we get very active, and sometimes we forget to speak to the patient that's laying in front of us. And sometimes, you know, the family, we want them out of the room so we have room to work, and they're not, and it just causes a lot of anxiety. So just try to always make sure we keep that good communication with our patients. Take the time to lean over and let her know that we're doing what we can and that we're supporting her, and also make sure at least one person on your team will at least just address the family and make sure they're okay. Also, we need to support in our institutions the culture of bundles and debriefs. This is not to be a culture of blame. It is to be a culture that we can sit around and how we can explore and diagnose and figure out how we're going to move forward. So in the prenatal part of the pregnancy, then we need to do a risk assessment. So if they have a suspected previa, accreta, increta, procreta, we know that they're already at risk. Pre-pregnancy BMIs, these are from ACOG, these slides, and basically some BMIs, when you do through the research, even patients over 40 BMI are at risk. They're clinically significant bleeding disorder, whether they already have low platelets, other significant medical surgical risk. It just depends. You know, the patients that's had multiple C-sections are already got that scarred uterus, and that puts them in another high risk. So when your patient walks in to labor and delivery, we can easily, and we can make this a checklist, you can easily look and decide when you go through the obstetric history, if they have a prior cesarean or any uterine surgery whatsoever, then that automatically is one risk factor. If they're multiple gestation, which we always know these patients are at a higher risk for bleeding, if they've had the grand mole tips greater than 4 births, where they've had a history of a postpartum hemorrhage or any obstetric hemorrhage, if the babies, those large macrosomic babies, the obesity once again, or if they're already anemic. These are patients that automatically need a type and screen. Different institutions have different rules about blood work upon admission. Most places are actually doing the type and screen, the CBC, and checking the platelets prior to or upon admission. Some institutions don't. So at least on any of these patients, at least have the type and screen so we can verify that blood type. Our high-risk patients are the ones that have the placenta previa, the low-lying placentas. The suspected accretas, those are definitely worrisome to have to be aware of. If your platelet count is less than 70,000, if there's any active bleeding, any known coagulopathies, or if you have 2 of the high risk or the medium risk risk factors, then they automatically put them into high risk categories. Those patients, we need to go ahead and do a type and screen. In the intrapartum, during our labor and delivery course, additional things that can prevent or can lead to more risk for the for the hemorrhages is chorioamnionitis, which we can monitor closely with the blood, with the temperatures and the vital signs, etc. Prolonged oxytocin, when you've got those long inductions and you know those uteruses are going to be super lazy. Prolonged second stages and magnesium sulfate. So make sure, once again, those are typed and screened and that you have reviewed all the blood work that's going to be recommended for collection. The high-risk patients are the ones that start with the active bleeding during the labor. If they have 2 or more of the medium risk on admission or that develop during the intrapartum period, go ahead and type and cross them. The universal active management of the 3rd stage of labor, as we go ahead, generally in 1,000 cc's, whether you use LR, normal saline, or they go ahead and we always put an average of 20 units in to start off with, 20 units of Pitocin, Syntocin, oxytocin into the back. And you're basically going to titrate and open that up after the delivery of the placenta or at that time to get that uterus to go ahead and contract down. You're going to titrate that infusion rate as the placenta is delivered and as we're rubbing that fundus to seed. Make sure on your blood bank that you have a massive transfusion protocol, and make sure that you have a functioning emergency release plan and have the ability to obtain 6 units of PRBCs. Now, I know living in the UAE and at different facilities, some blood banks, they don't have much more than 4 units on hand. So what you need to do if you're in that situation is then you need to collaborate and work with your blood bank people and find out, so where are you going to get the additional units if we need it? How long does it take you to go from this hospital to that hospital? And how long does it take the driver to actually bring it back? And then we have to process to administer. These are things you need to keep in mind, because if you're going to activate a massive transfusion protocol, if you start to have a hemorrhage, you need to be aware, and the physicians need to know, I have this much blood available on hand now, and I know it's going to take them 2 hours to get me the next 4 units. So just please be aware of your resources around you and work with your blood bank and see how you can make this work safely for our OB patients. Have a mechanism in place to obtain platelets and additional products in a timely fashion. So basically, if you do the activation on an MTP, basically all you need to do is, it's just like any other code, any other process. If you're going to activate it, you should be able to pick up the phone and you should be able to call and say, activate the MTP. Or you can make one phone call and say, I have a hemorrhage, and then they should automatically know what to do. So the blood bank number needs to be available. You should have a policy in place. Know what the emergency release, like I said, how much you can get immediately, how long is it going to take you to get additional products, and what are the additional products? We're going to look at what the American College of Obstetrics and Gynecology, ACOG, has to say or recommends on this. If you don't have these products, then you need to work with other physicians, your hematologist, and your blood bank, and decide how can we best serve our patients. Make sure that, so how will the blood be brought to labor and delivery? This needs to be outlined in your policy. We need to assign in an obstetric hemorrhage roles and responsibilities. I often refer to this as, you have to think of it as like ACLS. You're still going to have designated team members that have specific roles that they need to do. We need to practice closed loop communication, and it needs to be clear and concise. It is an emergency. I know adrenaline's high, just like in a code blue. But if you know the steps and you have someone going through the checklist and you practice an organized delivery of these steps, then you save time and you save lives. How will additional blood products and platelets be obtained? We've already discussed that. And how, working with the lab. Okay, if I need to do this, they need to know when you call and say, I have an obstetric hemorrhage, and you pick up the phone, that your blood is going to take priority, just like an emergency coming in through the ER. So you can read over this on when you review the slides. The anesthesia will draw the labs and run it. We know how the team works. Anesthesia is managing airway and managing the lines, and then also the nursing team is running. And like I said, you need to be good communication with your lab and your blood bank. So what they recommend in this massive transfusion pack is to have 6 units of PRBCs, 4 units of fresh frozen, and 1 pack of platelets. So basically, this is going to give you the outline of the transfusion rate, and I'll let you review that with your own on your own time. What I'd like to focus on is also having these hemorrhage carts available in the units is so nice, because everything is right where you need it. You need to have all your instruments and your emergency things, consumables ready to go. And on the cart, it's mobile and can go anywhere. Then in your medication fridges, you need to have a little box of the medications that you need that are specific for hemorrhage, and they're not mixed in with the floor stock. So what's recommended in these carts is to have the vaginal retractors, a weighted speculum. Everything we have, we need long instruments, because we need to be able to find, in case it is a laceration, then we need to be able to reach wherever it is to correct it. We need an intrauterine balloon, banjo curettes to do those curetages. Make sure you have good lighting so you can actually visualize when you're trying to do your inspection. You can actually visualize and see if you can see where the laceration is, if it's a cervical or some vaginal sidewall that's bleeding. And also because we don't use the balloons very often, make sure that there's, believe it or not, make sure your instruction book is right there, or a sheet that will give you just quick instructions. For cesarean or laparotomies, we just need that hysterectomy tray. Your sutures, we're going to run over those. You can use your intrauterine balloon there as well, and using the B-Lynch and other suturing on the uterus to help control bleeding, so we can try and save that uterus and not go straight to a hysterectomy. So the recommended medications for the hemorrhages is to have your oxytocin, syntocin, pitocin in pre-mixed bags. Here's your solution and the recommended dosaging. Usually they come in 500 with, you can get them with generally about 10 units in each one, or 20, you can add additional. You want 2 ampules, so you can do either a quick IV push, or you can go ahead and do your IM injections. The Hemabate, your Carboprost, make sure you have at least 1 available. I know it's expensive, but have it available. Side attack, that's sometimes a little tricky in this part of the world, excuse me, to be able to have these drugs available. But I do know that if you work with the government responsible people for the approval of these medications, generally, I'm finding it easier now that we can actually have them available. And your 1 ampule of Methergin. So basically, when this hemorrhage checklist begins, we're going to call for assistance when you notice it's happening. And then you need a designated, like we said, we will have assigned task and people with certain responsibilities. So you have your team leader, you're going to have your recorder, just like in ACLS or a code, your primary RN that knows the patient's history and knows what's happening, who can give a quick, brief report when someone walks in the door as another team member comes in to help. Announce what your cumulative blood loss is, and to say it out loud. I now have this, I now have 500, I now have 1,000, I think we're going into 1,500, and our blood's changing. Everyone can know in their head what stage they're in on the hemorrhage, and everybody can anticipate and move forward. We need someone to constantly monitor the vital signs and then to determine what stage that we're in. So quickly, we're going to look at the stage 1. On the initial stage, you want to make sure that this is your normal, this is your blood loss of greater than 500 or greater than 1,000 right at delivery. So they can still have normal vital signs and normal lab values. So we just want to make sure we have a nice IV line in. Generally, what we usually do in the US is put 18s in everyone that walks in labor and delivery. Trying to, some of the places I've been, I try to make sure that I get all the 22s off of labor and delivery, because there absolutely serves no purpose to have a 22 gauge IV on someone. So we just need to make sure we have IV fluids so we can give fluid boluses. Initially, we want to make sure when we notice we have get those Foleys in. We want to keep those the bladder, the uterus can contract. And plus, remember, there's about 600 or 700 mLs pumping through the uterus per minute. So they can quickly bleed out and become unstable soon. So that's why we want to go ahead and start to hydrate them. And we want to massage those funduses and those uteruses to see if we can get them to contract. We want to make sure that we're starting with our medications, and you can see on the right of the screen, these are your medications and dosages. You can go ahead, if you anticipate, call the blood bank and have them type in cross-match 2 units if you see that this is continuing and not stopping. And then we have to figure out why. Why is she bleeding? Does it have to do with her tone? Is there trauma? Is there laceration? Is there retained products that we need to go in and remove? Or is there some coagulopathy happening? So we need to first determine what it is, find the problem, and then fix it. If they continue to bleed, where your EBL is up to 1500, or you've used 2 uterotonics, you still have normal vital signs, but you know you're losing a good bit of blood, then go ahead and mobilize help. Place that second line. The second IV line should be 18, 16. Generally, over the course of my experience, we put an 18 in when they walk in the door. Every single OB patient gets 18. And then if at any point we expect a hemorrhage, the second one's a 16. So, and that way we want to have clear access where there's no doubt that we can completely run the fluids in and the blood in quickly if needed. Go ahead and draw your stat labs, prepare the OR. If your OR team is not in-house, then you need to call them and have them come on in, or at least be on standby depending on what their location is and how long it will take for them to get to the hospital. Go ahead and get 2 units of PRBCs, and depending on your facility, if you agree or have the ability to get 2 units of the fresh frozen. And then we need to escalate our therapy and goal of hemostasis. On the interim balloon technique, remember we're going to make sure you have your ultrasound machine available on the unit. So anytime this starts to begin that you have a problem, you need to make sure your cart's there, make sure your medications are there. You can go ahead and get your ultrasounds available. It's just having everything planned and ready instead of running around in 5 directions trying to find it and nobody can remember where it is. Inflate this balloon with 500 cc's of normal saline, and then you're going to, or water, sterile water, or saline. Use vaginal packing, and then with retraction, we always, once the balloon was inserted, we would pull back and tape it down to the patient's thigh. And then periodically, as the nurse checks, she will put more tension, pull tight on the catheter and tape it down to keep it nice and secure. You can do it through a transabdominal approach, which is very rare. And this talks through the steps on that as well. Surgical management, other than a hysterectomy, I have actually had the privilege of assisting with this in the US. Learning to do the different stitches on the uterus to help save the uterus, learning to do the ligation if needed. These are great techniques that anything we can do, like I said, to preserve the uterus. If all else fails and to save the mom's life, of course, we go on and perform that hysterectomy.
Carol, can you wrap it up, please?
Yeah,
it's time.
So here is stage 3. We'll let you look through. We just got to move forward. The only point is keep moving. As you know, things are changing. Move forward, move forward, move forward. Get your checklist. Have someone call it out as things are happening, so you don't forget a step. You don't forget the medication and the dose. And then always do the debriefings with the staff and and with the patient and the family. So we know that these steps actually save lives. And there's the maternal, there's a great research out of California where they were able to decrease 20% of their maternal deaths because of implementing small steps and organized bundles. So here's the references. Thank you very much for your time. And it's been a pleasure being with you this afternoon.
Thank you very much, Carol. This was so interesting. I was asked to take over again because, Amal, I guess your microphone is not working properly. I could listen to you so much longer, so interesting and so hands-on. Absolutely fabulous. Thank you so much. May I ask, do you have any questions? Just a short question to Carol, because we have to move on time-wise. Is there anything you'd like to ask Carol? Okay. And once again, Carol, thank you so much. Yeah, okay. So